Maria Mansour, clinical specialist for Pulmodine. I've been a registered respiratory therapist for over 30 years practicing in the Chicagoland area. Today I am going to show you the Blom Tracheostomy Tube and its 4 unique inner cannulas. Standard cannula, Subglottic suctioning cannula, speech cannula, and our low profile valve, which is used for spontaneously breathing non-ventilated patients. The Blom Tracheostomy Tube in use with the Servo300 ventilator. I will be demonstrating how the Blom Tracheostomy Tube interacts with the Servo300. This is the Blom standard cannula in use with the Servo300 ventilator. Settings are SIMV at 12, tidal volume of 600, and PEEP of 5. Insertion of the Subglottic suctioning cannula. You will now hear an audible click indicating the cannula is now secured to the Blom outer cannula. Now we are using the Blom Subglottic suctioning inner cannula. Our ventilator settings are the same, SIMV at 12, 600, and PEEP of 5. And as you can see, our peak pressure remains the same at 18. Now we're using our speech cannula. Our ventilator settings are the same as they were previously with the standard cannula and the Subglottic cannula. We have an SIMV at 12, tidal volume of 600, and a PEEP of 5. You will notice that our peak pressure has increased from 18 to 27. Reason being is the narrowing at the flap valve at the bottom of the cannula. This increase is only seen in the cannula and not in the lungs. During the use of the Blom speech cannula, the exhaled air is redirected through the fenestration to the upper airway to produce speech. No exhaled air is being returned to the ventilator for monitoring, causing the low minute volume alarm to sound. Disabling this alarm is not advised. The EVR is a small bellows device that prevents nuisance alarms, which can occur when using the Blom speech cannula. It is not necessary on the Servo300, although you want to turn your low minute volume alarm to its minimal active setting, in this case 0.2. Remember, when using the speech cannula, either active or passive humidification can be used. When using passive humidification like an HME, be aware that no heat or moisture is going to be exchanged while the speech cannula is in use. This is because all of the air is being redirected out of the upper airway rather than back through the HME. Auto-PEEP occurs when exhalation is incomplete. A percentage of the inspired air remains trapped within the lungs, causing a condition called auto-PEEP. If this condition becomes severe, pulmonary and cardiac issues can develop rapidly. A continuous high pressure alarm may be indicative of auto-PEEP or air trapping. If this scenario should occur, the speech cannula should be removed immediately and replaced with the standard cannula. Prior to reinsertion of the speech cannula, verify that the patient has a patent upper airway and consider repositioning the patient. Also, suctioning the patient above and below the cuff are recommended. If the ventilator starts to auto-cycle while using the speech cannula, decrease the sensitivity so that the ventilator is less sensitive. Or increase the inspiratory time so that it decreases the inspiratory flow when it comes into contact with the flap valve.